Welcome to ICU Primary Prepcast.
Hi, I'm Maddi.
Hi, I'm Swapnil. And today we are going to discuss about commonly used medication in ICU in regards to respiratory system. Are you ready?
Yes.
So Maddi, let's talk about one of the most commonly used drug in ICU, that is oxygen. Can you please describe the pharmacology of oxygen, please?
So oxygen is a colourless, odourless gas which is present in the atmosphere at a concentration of approximately 21%. It is used for the treatment of hypoxemia, carbon monoxide toxicity, migraines, to help in the reabsorption of pneumothoraces, and in hyperbaric therapy for the treatment of conditions such as necrotizing tissue infections, decompression sickness, air embolism, and delayed radiation injuries. Keep in mind, though, that most of the indications for oxygen are not evidence-based and hyperoxia is generally discouraged. We can think about the pharmacology of oxygen in terms of its pharmaceutics, pharmacokinetics, and pharmacodynamics. Pharmaceutics. Oxygen is a gas which is slightly denser and more viscous than air. It is produced by either using an oxygen concentrator or via fractional distillation of atmospheric air. In terms of its pharmacokinetics, we'll speak about the administration and absorption, distribution, metabolism, and elimination. Oxygen is available as an inhaled agent via variable intake devices such as nasal prongs or via fixed delivery devices such as through endotracheal tubes. It can also be infused intravenously or intraarterially such as via ECMO. Oxygen is also used externally such as in hyperbaric therapy. It is absorbed at a rate of 250 mL a minute in a person breathing room air and who's at rest. In terms of its distribution, oxygen diffuses across the alveolar membrane to enter the bloodstream, and its rate of diffusion is dependent on Fick's law. Oxygen is mainly transported in the blood by combining with hemoglobin, and a small amount is dissolved in the blood. It is metabolized in all tissues, mainly via cytochrome C mitochondrial enzymes, producing ATP, carbon dioxide, and water. The metabolism follows zero-order clearance kinetics and is approximately 200 mL per minute. The metabolites of oxygen, such as carbon dioxide, are transported back to the lungs and excreted via respiration. In terms of its pharmacodynamics, oxygen is required for oxidative phosphorylation, producing ATP that is needed for normal cellular function. Hyperoxia can cause multiple adverse effects, such as cellular injury due to increased reactive oxygen species, which can result in inflammation, secondary tissue injury, and cell death. Respiratory adverse effects, such as pulmonary vasodilation resulting in VQ mismatch, resorption atelectasis, bronchopulmonary dysplasia in neonates, tracheal irritation, and decreased vital capacity when a fraction of inspired oxygen is above 60%, dry nose and mouth, impairment of mucociliary clearance, tracheobronchitis, and it can worsen hypercapnia in patients who are CO2 retainers. Cardiovascular adverse effects include systemic vasoconstriction, reduced coronary blood flow by 8 to 29% if hyperoxic, increased myocardial infarct size, and no reduction in myocardial ischemia in the presence of coronary artery disease unless SATs are less than 85 to 90%. There's also been found to be an increased mortality post-cardiac arrest if hyperoxia is present with PaO2s of greater than 300 millimeters of mercury. Cns effects include retinopathy in premature infants, decreased cerebral blood flow by 11 to 33% in healthy adults. It can be associated with increased mortality in stroke and traumatic brain injury patients. And hyperbaric 100% oxygen can cause vertigo, convulsions, and loss of consciousness. Hyperoxia can also impair erythropoiesis if there's prolonged exposure to 100% FiO2. This shows that oxygen is not a benign drug, and many adverse effects are present if in the presence of hyperoxia.
Okay. One of the common scenario in ICU setting is young adult admitted to intensive care unit with acute exacerbation of severe asthma. Can you please classify the drugs used to treat severe asthma according to their mechanism of action?
Sure. So firstly, asthma is a lung disease characterized by reversible airway obstruction, airway inflammation, and increased airway responsiveness to a variety of stimuli. Acute severe asthma is commonly defined as an exacerbation that does not respond significantly to short-acting beta-2 adrenergic receptor agonists. The drugs used to treat these attacks aim to relieve the bronchoconstriction, reduce the inflammation, and decrease the hypoxia and work of breathing that is often present. Firstly, we'll think about the drugs that relieve bronchoconstriction, which include beta-2 agonists, muscarinic antagonists, methylxanthines, ketamine, volatile anesthetics, and magnesium. Beta-2 agonists are the mainstay in the treatment of acute asthma. Short-acting inhaled beta-2 agonists such as salbutamol are the primary therapy used. They bind to the G2 protein of adrenergic B2 receptors, increasing adenyl cyclase. Activation of the B2 receptors cause increased intracellular adenyl cyclase and cyclic AMP, which increases protein kinase A, decreases intracellular calcium, and inhibits the phosphorylation of myosin, resulting in bronchial smooth muscle relaxation. Nebulized salbutamol is generally given as first-line therapy, but intravenous salbutamol is sometimes given subsequently in severe cases. Adrenaline is another beta agonist that is sometimes used in severe asthma, either through nebulizers or intravenously. It also has alpha agonist properties, which may help in acute asthma by causing vasoconstriction and reducing the edema in the bronchi. Muscarinic agonists, such as ipratropium, are also used. These bind to the M3 receptor of bronchial smooth muscle and block acetylcholine. This blocks the increase in phospholipase C and intracellular calcium, thereby preventing airway smooth muscle contraction. They are generally added to beta agonist therapy in acute severe asthma. Methylxanthines, such as aminophylline, are phosphodiesterase 5 inhibitors, thus resulting in increased levels of cyclic AMP, causing bronchodilation. It does not produce additional bronchodilation when added to beta agonists and steroids, and has numerous side effects, thus is less commonly used now. Magnesium. The mechanism of action of magnesium is unclear, but is thought to block calcium channels and maybe also acetylcholine release at the neuromuscular junction, thus causing bronchodilation. Volatile anesthetics such as sevoflurane are thought to cause bronchodilation by reducing intracellular calcium in airway smooth muscle cells and by inhibiting acetylcholine release. Ketamine is also a drug that's thought to cause bronchodilation by blocking NMDA-induced bronchoconstriction and by preventing the reuptake of catecholamines, which act on beta-2 receptors to cause bronchodilation. Drugs that reduce inflammation and airway hypersensitivity and are used in acute asthma are steroids and leukotriene antagonists. Corticosteroids work by binding to the cell nucleus to inhibit the transcription of genes that encode inflammatory mediators. Their benefits include decreased inflammatory cell response, decreased mucus secretion, and increased beta responsiveness of airway smooth muscle. Early treatment with steroids decreases the likelihood of hospitalization and reduces mortality from acute asthma. Leukotriene antagonists, such as montelukast. Competitive antagonism at leukotriene receptors reduce leukotriene-mediated bronchoconstriction and the release of inflammatory mediators. There is insufficient evidence to recommend their use in acute severe asthma. Finally, drugs that reduce hypoxia or work of breathing. Oxygen is vital in the treatment of acute severe asthma, as hypoxia is the main cause of death in these patients. The other medication sometimes used is Heliox. There is evidence that a mixture of helium and oxygen may aid in the treatment of patients with acute asthma due to its lower density and turbulence compared to air, thus reducing airflow resistance and work of breathing.
Okay, so one of the class that you mentioned is the beta-2 agonist. which is commonly used to treat patients with asthma and also to treat patients with exacerbation of COPD. Can you please just compare the pharmacology of salbutamol versus salmeterol?
Salbutamol and salmeterol are both beta-2 agonists that result in bronchodilation. However, salbutamol is short-acting, whereas salmeterol is long-acting. Their pharmacology is divided into pharmaceutics, pharmacokinetics, and pharmacodynamics. Pharmaceutics. Salbutamol is available as a metered dose inhaler of 100 micrograms a puff, nebules of 2.5 or 5 milligrams, or ampoules of 500 micrograms a mil or 5 milligrams per 5 mils for intravenous use. Salmeterol is only available as a metered dose inhaler of 50 micrograms a puff, or in combination with fluticasone in a variety of strengths. Salmeterol should not be used as monotherapy without a corticosteroids, as it has minimal anti-inflammatory effect. Pharmacokinetics. Absorption/administration. Both salbutamol and salmeterol are rapidly absorbed following aerosol administration. Salbutamol can be given via inhalers, nebulizers, or intravenously, whereas salmeterol can only be given via inhalation. Salbutamol has a rapid onset of action of 2 to 5 minutes via inhalation and 1 to 3 minutes intravenously, whereas salmeterol takes about 30 minutes for onset, with a peak effect occurring between 3 to 4 hours. However, salmeterol has a longer duration of action of 12 hours compared to just 3 hours for salbutamol, making it more effective for long-term treatment of reversible airway obstruction to reduce the frequency and severity of asthma or COPD exacerbations. It is not useful in the treatment of acute asthma exacerbations. Distribution. Salmeterol is over 10,000 times more lipophilic than salbutamol and is extensively bound between 95 to 98% to plasma proteins, whereas salbutamol is only 10% protein bound. This lipophilicity accounts for some of its longer duration of action. Salbutamol is hydrolyzed by esterases in the blood and tissue to the active metabolite colterol. This is then metabolized by conjugation to the liver and GIT to salbutamol 4-O-sulfate. Salmeterol is metabolized in the liver by hydroxylation via cytochrome 3A4. Elimination. Salbutamol is excreted in the urine and feces, 30% unchanged in the urine and about 45% as metabolites. Salmeterol is excreted mainly in the feces and a very small amount in the urine. The half-life of salbutamol is 2 to 5 hours, whereas salmeterol's half-life is longer at 5.5 hours. In terms of its pharmacodynamics, salbutamol and salmeterol are both beta receptor agonists, which are highly specific for beta-2 receptors. However, salmeterol is 15 times more potent than salbutamol at beta-2 receptors and 4 times less potent at beta-1 receptors. Salmeterol binding is non-competitive and has a long lipophilic side chain that binds to the exosites near beta-2 receptors in bronchial smooth muscle. This allows a part of the molecule to remain at the receptor site, resulting in a prolonged duration of action. By activation of beta-2 receptors, both of these drugs stimulate intracellular adenyl cyclase to catalyze the conversion of ATP to cyclic AMP, which increases protein kinase A. This decreases intracellular calcium and inhibits the phosphorylation of myosin, resulting in relaxation of bronchial smooth muscle. They also inhibit the release of hypersensitivity mediators from mast cells, including histamine. The pharmacodynamic effects of salbutamol and salmeterol are similar and can be classified by system. In terms of respiratory effects, they cause bronchodilation. However, they may reverse hypoxic pulmonary vasoconstriction, resulting in further hypoxemia. Salmeterol should not be used in acute asthma attacks due to its slow onset of action. Cardiovascular effects include tachycardia and increased contractility due to stimulation of beta-1 adrenoreceptors. This is less common with salmeterol due to its high beta-2 specificity. Vasodilation and hypotension can result due to beta-2 stimulation. Metabolic effects include hypokalemia due to the stimulation of sodium-potassium ATPase. Thus, salbutamol is sometimes used as an adjunct in the treatment of hyperkalemia. Hyperglycemia can result due to stimulation of glycogenolysis and gluconeogenesis, but this is usually only an issue with high doses during acute attacks. Lactic acidosis can occur with high doses of salbutamol due to beta-2 stimulation of anaerobic glycolysis. If production of lactate exceeds hepatic clearance, then acidosis results, which can cause increased respiratory rate and be mistaken for worsening asthma. These metabolic effects appear to be attenuated after chronic use. Other effects include tremor, muscle cramps, uterine relaxation in the gravid uterus.
Thank you. Can you please compare and contrast the pharmacokinetics and adverse effects of ipratropium bromide versus aminophylline?
Aminophylline is a 2-to-1 complex of theophylline and ethyllenediamine and dissociates to theophylline in biological fluids, which is a xanthine derivative. Theophylline competitively inhibits phosphodiesterase, which is the enzyme responsible for breaking down cyclic AMP. It is used for the treatment of bronchospasm due to asthma, emphysema, and chronic bronchitis. Ipratropium bromide is an anticholinergic agent which blocks muscarinic cholinergic receptors, thereby causing bronchodilation and inhibiting vagally mediated bronchoconstrictor reflexes that are thought to occur in patients with asthma and COPD. It is used for the treatment of bronchospasm associated with asthma and COPD and for the treatment of rhinorrhea associated with rhinitis. Pharmacokinetics can be classified as administration/absorption, distribution, metabolism, and elimination. Ipratropium can be given as a nebule, inhalation, or nasal spray, whereas aminophylline can only be given intravenously. Approximately 10 to 30% of the dose of inhaled ipratropium is deposited in the lungs and is rapidly absorbed within minutes. The onset is within 3 to 5 minutes, but peak effect is not reached until 1.5 to 2 hours, and duration is up to 6 hours. Aminophylline has an onset of about 15 minutes and a duration of 4.5 hours. Distribution. Ipratropium has a volume of distribution of 4.6 litres per kilogram and is minimally protein bound, whereas aminophylline is 60% protein bound and has a much smaller volume of distribution of 0.3 to 0.7 litres per kilo. Ipratropium does not cross the blood-brain barrier, unlike aminophylline. In terms of the metabolism, ipratropium is partially metabolized to 8 or more metabolites via hydrolysis and conjugation, and this results in inactive metabolites. Theophylline undergoes hepatic metabolism via the cytochrome P450 system to inactive metabolites. Ipratropium is eliminated renally via active secretion with a half-life of 2 to 4 hours. Aminophylline is also excreted renally with a half-life of 7 to 9 hours, but this is increased in the elderly and in patients with congestive cardiac failure, COPD, cor pulmonale, or liver disease. Interestingly, the half-life of aminophylline is decreased in smokers. Now to talk about the adverse effects. Ipratropium has minimal side effects due to its low systemic absorption and the fact that it does not cross the blood-brain barrier. Its adverse effects mainly stem from its anticholinergic properties and thus should be used with caution in patients with glaucoma or urinary tract obstruction. Adverse effects are rare but include tachycardia, palpitations, nausea, constipation, dry mouth, rash, acute angle closure glaucoma, and urinary retention. Aminophylline, on the other hand, has a low therapeutic index, and thus daily serum levels are measured, aiming for 5 to 20 micrograms per ml. Levels above 20 micrograms per ml generally produce toxicity. Adverse effects are numerous and can be divided by system. Cardiovascular effects include tachycardia, palpitations, arrhythmias, and hypotension. Central nervous system effects include headache, anxiety, insomnia, dizziness, lightheadedness, tremor, and seizures. GIT effects include nausea, vomiting, epigastric pain, anorexia, diarrhea, and heartburn. Genitourinary effects include increased urination, and respiratory effects include tachypnea.
Thanks, Maddi. Do you have any questions?
Yes, my favourite questions. So I've got one for you. How did oxygen's date with potassium go?
Oxygen dating with potassium. O2 with K? O2K?
Pretty close. It went okay.
Oh, I'm getting closer now. Thanks, Maddie. Thanks a lot. So that's the end of our podcast on the pharmacology of respiratory system. Next time we will be back with pharmacology of GIT. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.